everybody. Have no disclosures. We're talking about laparoscopic tap blocks that we do here as part of our multimodal pain management strategy like we've been talking about throughout this whole conference. And so to reiterate what we've been saying through many of these presentations, it's the multimodality pain management is a central tenet of the ERAS protocols. With the laparoscopic tap blocks, these have been widely adapted by surgeons of all sorts of specialties because they're easy to perform, they're quick, you don't have to wait for anesthesia to do them, and they have been shown to reduce opioid use. So I'll talk briefly here about the important part of the laparoscopic tap block is really knowing your anatomy. If you're not in the correct plane, it's not gonna work. And so like Dr. Pearson was talking about yesterday where he uses the ultrasound, this is a picture of the ultrasound with the different muscle layers. There are 3 different muscle layers in the abdominal wall with fascial covering. So that's important when we have the tactile feedback when we do these blocks. The first one here exteriorly is the external oblique followed by the internal oblique and then the transversus abdominis. And the neurovascular bundle, the place where we want to go here is in between the internal and the transversus. And that has the upper and lower tap plexus, intercostal, subcostal, and the L1 segmental nerves. Here's just another view of that here. This yellow line here is representing the nerve, and then it's in between that second and third muscle layer here. This is really where we want to target that in our laparoscopic approach. And it's important to stress here that the traditional tap block is really optimal for incisions below the belly button, so T10 to L1. And so if you have an incision that goes all the way through the whole abdomen, or if you have a supraumbilical component, it's really important to incorporate the subcostal or rectus block, which will provide an upper plexus block, the T6 through T9, in addition to the lower plexus block, T10 through L1, which is the traditional tap block. So there's a variety of block techniques. I won't touch through all of these in detail. We'll kind of talk through the ultrasound tap next, and transversus the TF block is coming after that, and the QL block, mainly talking here about the laparoscopic. But we'll kind of talk first about where this all started with the classic tap block, which is a posterior approach. Here's kind of the main ones here. The blind tap I'll talk about next is kind of from this angle in the back, but kind of along the